Thank you to Patrick Marcelin for his kindest invitation to speak about immunotherapy, when and how. If I would be the general manager in my hospital, the presentation will have an end right now, because there's no when. None of the immunotherapy agents are approved by the AMA. None of them are similarly reimbursed in most of the European countries. But I will show you some of the reasons why I think any physician interested or treating hepatocellular carcinoma has to learn what immunotherapy can provide to patients. So my disclosures going in different directions, so pretty balanced. So for those of you who are not experts, if you're an expert, please forgive the naiveness of these slide. The ability of the body to reject a tumor by the action of the immune system depends basically on two things. Whether the tumor can be recognized by the immune system, we call this antigenicity. It depends on lots of things, appropriate presentation of unique peptides on HLA molecules to the antigen-presenting cells, priming of these cells, maturing of these cells, and ability to travel to the lymph nodes where they can get in contact with the immune system. And then if eventually that happens and the immune system learns there is a tumor there, then it would all depend on how effective the response is in terms of trafficking the cells into the tumor and then identifying, recognizing the tumor cells there and rejecting them. So basically what happens is that if there is no antigenicity, there is no immune rejections. And this, then the T cell response, the intensity of the T cell response is no longer a problem. On the opposite hand, if a tumor is quite antigenic and the T cell response is powerful enough, there will be no tumor. And this is theoretically what is supporting the fact that despite all of us aging and our livers, if we have a chronic liver disease, being prone to develop tumors, many patients die without having a tumor in his whole entire life. But if the T cell response is there but is impaired, then the tumor appears, but the tumor is infiltrated by a number of effector T cells that nevertheless are not able to completely eradicate the tumor. Now, of course, there's lots of gray intermediate scenarios where there is a balance between tumor growth and immune response. And I think this is, reminding this is important because it highlights the first idea. For many of the drugs that we will discuss, you need T cells to infiltrate the tumor. There are a number of things that you can do playing with the immune system to try to arrest or tumor growth or eliminate the tumor. Many have to do with educating or selecting the T cells to make them more able to identify and kill tumor cells. But most of the data, and the reason why, probably why I'm here, come from the fact that some of the agents that we call immune checkpoint inhibitors have been effective in HCC and other tumors. What are these molecules? Well, just again to remind you, it is the engagement of a tumor, an antigen-presenting cell with a specific T cell, and the engagement of the HLA molecule containing the antigen with the respective TCR, T cell receptor, that triggers in the T cell a number of events that eventually lead to the presentation in the membrane of the molecule of some molecules that we call checkpoints, immune checkpoints. And why do we call them immune checkpoints? Because they are able to either further increase the activation of the T cells or the opposite, tone down and turn the T cells to a more inactive status. So these checkpoint molecules fine-tune the final T cell response in terms of tumor rejection. There are many of them. Some of them provide negative signals, some of them provide positive signals. And we have now is the ability through monoclonal antibodies to interact with them. If you interact with a checkpoint that sends a negative signal and you block that signal, the result is you enhance the T-cell response. But you can equally have this effect if you use an antibody that stimulates a checkpoint molecule that sends a positive signal. At the end of the day, what happens is that you are able to restore the T-cell function in a more effective way. Most of the interest has come from two checkpoint molecules, PD-1 that interacts with PD-L1, it's its ligand, and CTLA-4. And you can play with these PD-1, PD-L1 axis by targeting PD-1 with nivolumab, pembrolizumab, or others, or PD-L1, the ligand, with durvalumab or atezolizumab. Most of the experience that we have come from PD-1 inhibitors, and there are two brand names, nivolumab and pembrolizumab. They have been tested in sorafenib-experienced patients in a very advanced setting, large number of patients in phase 2 trials, and the results were that there was a class effect, not depending on the drug, but depending on the mechanism of action by which 15 to 20% of the patients achieved objective tumor remissions that were quite durable. In the case of Nivo, a median duration of response in HCV patients of 16 months, and in the case of Pembro, 77% during more than 9 months. And in parallel with these encouraging, I would say at least, a response rate, the survival rates for these very advanced patients were in between 13 and 16 months. And what I'm showing here, just for comparison, is the survival of patients treated with placebo in phase 3 trials with the same kind of population. And it was probably this difference despite being phase 2 trials, what led to FDA and regulatory agencies in many other countries worldwide to accept Nivo and Pembro for the treatment of sorafenib-exposed patients. But MSD conducted rapidly phase 3 clinical trials in this second-line setting, more than 400 patients randomized to Pembro or placebo plus best supportive care. You can see here the patients treated with pembrolizumab lived longer. The median was more than 3.3 months longer than placebo, and also a fair increase in the progression-free survival, with more than doubling the progression-free survival rate at 12 months. But unfortunately, these data, although statistically significant, did not meet this specified threshold for significance. There are a number of statistical or design issues behind these formal negative result of these trials showing an improved survival. We can talk about this in the discussion. But the fact is that if you are a patient with an advanced HCC and you receive Pembro or Nivo and you respond, what happens is that you definitely survive much longer. You can see here in the original Nivo phase 2 trial, survival rate 2 years after initiation of therapy in excess of 90%. And this is something that was unprecedented and we don't see with any other TKI inhibitor. And this happens despite the burden of disease. It happens with multinodular massive infiltration in the liver. It happens in patients with vascular invasion, even to the main trunk. It happens in patients with extrahepatic disease. And what is even more important, it can be persistence even after treatment is discontinued. And you can see, for instance, here in the right upper panel, a patient's free of disease 5 years after she discontinued therapy, something you certainly don't see with TKIs. Small fraction of patients get a very clear and prolonged benefit. Could we identify these patients up front? That would be the ideal thing to do. We have recently presented and will be publish the results from the biomarker studies on the 040 trial. We know that patients that have PD-L1 expression in the biopsies, it's around 20% of them, have a higher chance of responding. But as you can also see here, you can find objective remissions also in patients that have no PD-L1 expression. So alone, PD-L1 expression is not useful as a biomarker for selecting the patients. We were also able to see, and this is no surprise, that tumor inflammation, particularly increase in CD3 and CD8 lymphocytes, had a clear trend towards improved overall survival. So the more infiltration in the tumor, the better the survival. And for patients in which we were available to analyze RNA-seq, there were a number of signature scores that were tested. BMS was one of them, but any of them resulted positive in correlating with objective remissions and, what is more important, with improved overall survival. The problem is unlikely that these will be ready for clinical settings, and this will be valuable if a company, let's hope that this doesn't happen, wants to have a positive trial, because then you can select based on these biomarkers, and the trial will be enriched in respondents, the trial will be positive, but the population that has not these markers but still respond very well would be neglected, these kind of treatments. We do have also experience with immunotherapy in a population that has never been included in clinical trials, and these are patients with mildly decompensated disease. Single-agent PD-L1 or PD-1 inhibition has a very good safety profile, and this is also true for patients with child B status. As you can see here on the table, the rate of adverse events is as low, particularly grade 3 and 4, as low in child B patients as it is in child A patients. And also, the proportion of patients that respond is equally there. And some of these patients who are decompensated because of the tumor growth, when they respond to the immunotherapy, get recompensated again. So this was the reason for testing this in the first line. Another phase 3 trial comparing nivolumab in this case with sorafenib, more than 700 patients. And you can see that there was a slightly better survival in the nivolumab arm in blue, with a hazard ratio of 0.85. And again, unfortunately, the predefined threshold of statistical significance was not reached. So this is formally a negative trial, although there was a number of also design issues, but the fact is that quite a majority of the patients in the sorafenib arm got immunotherapy after progression. So there are a number of confounders there, but nevertheless a negative trial. This is why this is not approved in any country so far. Tolerability, no doubt, much better in terms of number of all grades or grade 3 and 4 adverse events. And probably, and this is just a personal opinion, this is a similar slide that Pierre has presented before. I do believe there is still, if a physician has the possibility and a patient has the possibility to get access, there are two situations where these could be selected use. One is that 10 to 15, 20% even of patients that have formal contraindications for TKI inhibitors. And there, I do believe nivolumab could still be a valuable option for these patients. And then patients that at the second line setting do have similarly contraindications for anti-angiogenics. And these are basically patients with recent cardiovascular events. But it was clear that from the beginning that with 15 to 20%, we needed something else to make immunotherapy a great success for the majority of the patients. There are a number of things that are being explored, vaccination by different platforms, but probably what is more obvious is to try to improve the immune response by combining different immune checkpoint inhibitors, because they act at different points and do have a different mechanism of actions. And in this regard, I would like to come back to the first trial that was reported. We had the opportunity to show that tremelimumab, which is a CTLA-4 blocking agent, had a 18% response rate. So HCC is CTLA-4 blockade a responsive tumor. And this was indeed tested with another checkpoint inhibitor, ipilimumab. It's also a CTLA-4 blocking agent, in different combinations with nivolumab, different doses, in patients with second-line post-sorafenib. And you can see here, response rates go up to 30%, and median overall survival in second-line setting can go up to almost 2 years. Another way of combining is with things that may elicit tumorigenicity, but also is combining with things that may increase the priming phase of the immune response. One of these potential agents are VEGF inhibitors. And this is what is behind the IMbrave 150 study that tested versus sorafenib the combination of atezo, which is a PD-L1 inhibitor, and the anti-angiogenic agent bevacizumab. And on the first interim analysis, the trial was stopped for efficacy. You can see here that the median overall survival in the combination arm has not yet been reached, but the hazard ratio for survival is less than 0.6. And similarly, this hazard ratio for progression-free survival is less than 0.6. No doubt these results will transform the first-line setting. These are the recommendation of in the ESMO guidelines as of today, quite similar from what I've proposed before, but very likely, and the sooner the better, we will have the combination as a first-line setting. We will then drive the TKIs to second and third-line therapies. We'll remove immunotherapy from the second or third-line scenarios, and will certainly put us in a difficult situation because none of these TKIs have been tested post-immunotherapy. There are a number of ongoing trials testing other combinations. I would highlight the combination of CTLA-4 plus PD-L1 inhibition, but also the combinations of TKIs, cabozantinib, and lenvatinib with PD-1 or PD-L1 blocking agents. But we have to be careful. This is just the preliminary analysis of one such combination, pembro and lenvatinib. You can see here the response rate goes up to almost 60%, more than 50%, but the rate of serious adverse events is also 50%, including some grade 5 resulting in death adverse events. Of course, this may be a learning curve, and we will have to wait for the phase 3 trial that is already ongoing, but just to highlight that toxicity may become a problem with this combination as well. So if any of these combinations is also positive, we will be in a scenario which probably the first line of treatment would be a combination of either 2 checkpoint inhibitors or a checkpoint inhibitors plus a TKI or VEGF inhibitors. And then we will have all the other TKIs listed without any clue as to how to use it. We will have to do our best in designing good research studies to solve these questions. So my take-home messages, I thought I have convinced you that immunotherapy using immune checkpoint inhibitors will have a large impact on HCC management due to the ability to produce durable and clinically meaningful responses. So far, the combination of atezo and bevacizumab may become the standard of care for first-line therapy, and this will certainly impact downstream options. Single agents or combinations of immune checkpoint inhibitors with other drugs are being tested across tumor stages, but we have to take into account that these combinations carry significant toxicities in cirrhotic patients that demands specific workup for diagnosis and management. And I have not touched on how to use the immunotherapies, but I will leave you with the possibility to get more informed in this review that will be released soon, probably by next month. I would just like to finish definitely by inviting all of you who would be interested in the treatment of liver tumors to the annual conference of the International Liver Cancer Association that will take place in Spain, quite close to France. This is a perfect place for all of you who want to get more information about this. Thank you very much for your attention.